Hello, I'm Manoj Karmakar. In this next video, Dr. Shinichi Sakura from the Shimane Medical University in Shimane, Japan, is going to be discussing with us the innervation of the knee joint and the best practices for postoperative analgesia after total knee replacement. If you are liking our videos, do remember to like and share these videos with your friends and colleagues. If you still haven't subscribed, do remember to subscribe so that you can get regular notifications of any future uploads. Now enjoy the upcoming video.
Good evening, good morning, or good afternoon, everyone. I'm Shinichi Sakura, an anesthesiologist working at Shimane University Hospital in Japan. First, I'd like to thank Dr. Kamaka for the invitation and opportunity to give a lecture in this webinar today. In my talk, I'd like to share with you the latest information on regional anesthesia for total knee arthroplasty. First, I'd like to focus on the innervation of the knee. Then I'll cover most of the regional techniques available now for total knee arthroplasty, followed by a pain management protocol that best works in my institution now. The pandemic has taken a toll on every aspect of our daily life. However, I hope we have already seen the worst. My town is a popular tourist destination because of Izumo Taisha Shrine that is one of the most prestigious shrines in Japan. This picture shows what the shrine looked like during the pandemic, a few months ago. But now we can see tourists coming back. I like to believe we are seeing the light at the end of the tunnel. I have nothing to disclose in relation to this presentation. Total knee arthroplasty is a measure to relieve pain and regain normal activities. To reach the goal, rehabilitation process plays a crucial role. It can help the patients heal from surgery faster and greatly improve their chances for long-term success. However, several factors can prevent rehabilitation. First, pain. Without adequate pain control, doing exercise is impossible. Second, nausea and dizziness that often comes with opioid analgesics. An ideal analgesic regimen should reduce opioid consumption. And third, muscle weakness. You need a certain degree of muscle strength, for example, to stand up and ambulate. In that regard, regional anesthesia can play an important role. To achieve the goals, you need to understand how the knee is innervated. This slide shows a typical dermatome map of the nerves in the lower limb. Nerves from the lumbar plexus, including femoral nerve and lateral femoral externus nerve, are responsible for sensation in the anterior knee. Nerves from the sacral plexus, mostly sciatic nerve, are responsible for dermatomal sensation in a distal part of the anterior knee and the posterior side of the knee. Regarding the knee joint, basically four nerves supply the sensation: femoral nerve, obturator nerve, and the two components of the sciatic nerve, tibial and common peroneal nerves. Previous cadaveric studies have further identified the articular branches that are responsible for sensation of the knee joint. This slide shows the list of the nerves innervating the anterior aspect in each quadrant. We now know that the anterior knee joint is innervated by at least 10 nerves, including the nerve to vastus medialis, intermedius, and lateralis, and saphenous nerve, common peroneal and recurrent peroneal nerves, and four genicular nerves that originate from the nerve to vastus medialis, tibial nerve, and common peroneal nerve. Regarding the posterior knee joint capsule, previous cadaveric studies have found that articular branches of tibial nerve and posterior obturator nerve form a fine plexus called popliteal plexus. In addition, a posterior branch of common perineal nerve separately contributes to the sensation. Then you decide which regional anesthesia techniques to use. Here, let me remind you that all the nerve fibers to the knee originate from these two major plexuses, lumbar plexus and sacral plexus. Femoral, obturator, and lateral femoral cutaneous nerves are branches of the lumbar plexus. Sciatic nerve is a branch of the sacral plexus. Neuraxial block, epidural block, can block both plexuses, but may not help achieve the goal of total knee arthroplasty because it causes muscle weakness in both legs. Instead, peripheral nerve blocks are a better choice if you have enough knowledge of what each block can offer to a patient and have the skill to conduct them. For the next 20 minutes or so, you will hear about these blocks one by one. First, femoral nerve block that has been a kind of gold standard for a long time. Because the landmark is very clear, especially by using ultrasound, it's one of the least technically demanding peripheral nerve blocks. Continuous femoral nerve block works reliably most of the time. Many studies have shown that femoral nerve block can provide similar pain relief to epidural analgesia after total knee arthroplasty. However, blocking femoral nerve results in quadriceps muscle weakness, which may limit physical rehabilitation like gait training and stair climb practice. Nowadays, rehabilitation starts on the first post-operative day in many institutions. That is why adaptive canal block was developed and has become popular recently. Why adaptive canal block? Anatomical textbooks describe that all the motor branches to the sartorius and quadriceps divide from the femoral nerve before they enter the adaptive canal. That is here. Here, the nerve consists of only saphenous sensory nerve. So the idea behind this block is to perform a conduction block mostly on the sensory branches of the femoral nerve. But what is adductor canal in the first place? The adductor canal is a narrow conical tunnel. It is 10 to 15 centimeters long between the apex of the femoral triangle and the adductor hiatus of the adductor magnus. The canal serves as a passageway of vessels and nerves moving from the anterior side to the posterior leg. However, few people conduct this block as indicated by the name. These two papers published by the group of anesthesiologists who developed this block shows that pain scores after adductor canal block were similar to those after femoral nerve block. But quadriceps muscle strength was more preserved after adductor canal block compared with femoral nerve block, which is good. However, in the text, they said the block was conducted at the mid-thigh level. What does that mean? Can we call them adductor canal blocks? The left-hand side figure shows the mid-thigh level with a red arrow and the proximal end of the adductor canal with a blue arrow in 4 different people. So it is clear that the mid-thigh level is proximal to the adductor canal. But come to think of it, it makes sense to conduct a block around the mid-thigh level because only saphenous nerve runs inside the canal, and other nerves, such as the nerve to the vastus medialis, that are also responsible for knee cessation, leave the femoral nerve before entering the canal. So in summary, to be accurate, the adductor canal block is the femoral triangle block in most cases. This slide shows the catheter we inserted for continuous adductor canal block at the mid-thigh level before surgery. Next, obturator nerve block. As I showed you before, posterior branch of the obturator nerve is partly responsible for pain in the posterior knee. After coming through the obturator externus, the posterior obturator nerve runs between the pectineus, that is that here, and the adductor brevis, and the adductor brevis and the magnus muscles. So you block the nerve around here or wherever. It is also a very easy block to perform. Some previous studies have shown that obturator nerve block is worth conducting. For example, in this study, the authors compared a single femoral triangle block alone, combined single femoral triangle block and obturator nerve block, and local infiltration analgesia. And they found that adding obturator nerve block to femoral triangle block significantly reduced pain as well as opioid consumption compared with a single femoral triangle block or local infiltration analgesia. So in conclusion, obturator nerve block can help when it is combined with femoral triangle block for post-operative analgesia after total knee arthroplasty. As I showed before, a part of the anterior knee joint and most of the posterior part are innervated by tibial and common peroneal nerves. So it makes sense that sciatic nerve block has been conducted together with other nerve blocks, such as femoral triangle block. Both proximal and distal approaches have been used for the sciatic nerve block. Some people question the importance of posterior knee pain after total knee arthroplasty. However, evidence tells its importance. For example, in this study, patients undergoing total knee arthroplasty who received spinal anesthesia and continuous femoral nerve block were divided into 3 groups to receive proximal sciatic nerve block, distal sciatic nerve block, and no block. The results showed that the proportion of patients who experienced moderate to severe posterior knee pain at 6 hours was 80% without sciatic nerve block, but fewer than 20% when proximal or distal sciatic nerve block was conducted. Anterior knee pain was also significantly less frequent after the addition of sciatic nerve block. Previous clinical studies have compared many different regional techniques. This network meta-analysis evaluated those different regional techniques and ranked them based on pain scores, opioid consumption, and range of motion after total knee arthroplasty. And the authors found that conducting multiple nerve blocks was more effective than any single nerve block. And a combination of femoral nerve block and sciatic nerve block was the best approach. Conducting multiple peripheral nerve blocks has been a common practice in many major orthopedic centers. This very recent study was conducted to see if dexamethasone prolonged the analgesic effects of a combination of sciatic nerve, lateral femoral cutaneous nerve, and obturator nerve blocks, and IV dexamethasone in patients undergoing total knee arthroplasty. The results showed that the combination of these nerve blocks worked really well, and more than 60% of the patients did not receive additional analgesics for 20 hours post-operatively, regardless of dexamethasone. However, like femoral nerve block, sciatic nerve block is associated with drawbacks, such as undesirable motor block of the leg. In 2012, Dr. Sinha presented a new technique called IPAC block at an ASA meeting in San Diego. I think this was a kind of a game changer. Similar to sciatic nerve block, IPAC showed for the infiltration between the popliteal artery and the capsule of the knee, targets nerves that are responsible for pain in the posterior knee. But as opposed to sciatic nerve block, this block is expected to block only the terminal sensory branches and spare the main trunks of the common peroneal and tibial nerves. Does the injected expand enough to reach the articular branches in the popliteal region? This cadaveric study observed the dye spread distribution, and they found that dye injections produce dye spread in the popliteal region and extensive staining of the articular branches. Does IPAC block work as expected? That is, in the presence of single or continuous adductor canal block, does the IPAC block improve pain relief? This review analyzed the results of previous clinical studies and found that the additional benefits of IPAC block were apparent, especially when local inflation analgesia was not conducted. Another recent review also shows that in conjunction with single or continuous adductor canal block, the IPAC block may be superior to local infiltration analgesia. And even in the presence of local infiltration analgesia, IPAC block has additional analgesic effects. However, IPAC block is not perfect either. Local anesthetic injection is made only around the articular terminal branches, so no spread is expected to reach the sciatic nerve itself. However, the result of a recent study showed that that is not the case. In the study shown in this slide, the analgesic effect of IPAC was inferior to the tibial nerve block, especially when IPAC block was conducted at the proximal site. In addition, IPAC produced sciatic nerve block in some patients. My personal experience also tells that more than 5% of patients receiving IPAC block develop motor weakness in the ankle. This is a video showing how we conduct IPAC block and continuous femoral triangle blocks in our institution. We keep a patient in the supine position with the legs slightly flexed and the external rotated. We conduct IPAC block first. You can see the needle coming from the right side, anterior side to reach between the popliteal artery and femur. You can see the medial epicondyle there. The injection is being made. After injection, we put the needle, and then we conduct femoral triangle block at the mid-thigh level. The needle is coming through the sartorius muscle here. And after pop, you can inject local anesthetic. And this. Then we put inside a catheter in the space we made with the local anesthetic. We're just pushing in the catheter. To leave the tip of the catheter inside of the space we made. Then we check to see if the catheter tip is located in the right place by injecting solution and air. Now you can see the air injected. As I showed you before, genicular nerves are sensory nerve branches in the knee joint. Early papers have described radiofrequency ablation and blockade of genicular nerves to treat severe chronic pain in the knee. Recently, some researchers have started using this technique to treat post-operative pain after total knee arthroplasty. For this purpose, the targets of genicular nerve blocks are the superior medial, inferior medial, and superior lateral genicular nerves. The inferior lateral genicular nerve blocks should not be conducted because the site of injection is very close to the common peroneal nerve. This video shows how we conduct genicular nerve blocks, superior medial, and then inferior medial genicular nerve blocks. Genicular nerve runs on the, this was a superior medial genicular nerve runs on the surface of the femur. So you inject on the surface, local, on the surface of the femur. Then inferior medial genicular nerve here lands on the surface of tibia. You cannot see the nerve. It's very tiny nerve. So this is a retrospective study conducted to see if genicular nerve blocks alone were effective pain relief after total knee arthroplasty. The authors compared genicular nerve blocks and local infiltration analgesia in patients who received spinal anesthesia. And they found that the two techniques offered similar pain relief when used alone. Here. This slide shows the first randomized study conducted to see if adding genicular nerve blocks to a combination of continuous adductor canal block and IPAC block improved post-operative analgesia further. The authors compared two groups of patients who received genicular nerve blocks using bupivacaine or saline. They found that opioid consumption for 24 hours was significantly lower in the block group compared with the sham or saline group. Pain scores were also lower at 6 hours in patients who received genicular nerve blocks. So their result suggests that genicular nerve blocks may improve pain relief when combined with IPAC and adductor canal block. Should we include genicular nerve blocks in a group of routine blocks? Routine blocks for total knee arthroplasty? I think it's too early to tell the answer. In this study, no initial bolus injection was made for adductor canal block before continuous infusion, and the decrease in pain intensity was observed only for 6 hours. Genicular nerve block is an easy technique for sure, but adding this block to other blocks may be redundant too much, and the benefit may be limited. So I'm not sure if the blocks will be here to stay. We need to have many studies, clinical studies, to prove this is important block. In this lecture, I have shared the latest information on these blocks. Based on the benefits and risks of each technique, here is the pain management protocol in my institution. Our first choice is a combination of continuous adductor canal block, femoral triangle block, and IPAC block, unless requested otherwise. Continuous infusion of levobutyl is continued for 1 to 2 days, depending on the patient. However, the best practice depends on many factors. Expectation of a patient should be different, and surgeons are different. The skills you have are also different. So there's no such a thing as the best practice for everyone. You should find your own best practice that works for you and your institution and your patients. That pretty much finishes what I'd like to talk about today. Thank you for your kind attention.